Very nice to be back. Good. Good. I heard that. Yeah. So, advanced directives, which all of you, or most of you, probably have. But still, I find that people have a lot of questions about these, so I want to spend a fair amount of time talking about them. But first, as promised, a quick review of 5 themes. And these are, useful to keep in mind as we think about advanced directives in terms of what are they and what are they supposed to be doing for us. First, in the first slide I think I put up the first day, learning to die is learning to live. The problems, mysteries, distinction of Gabriel Marcel, the question of what is a good death and how do we fill that in terms of particulars, the question of spiritual possibilities and what that means. And this last, I don't think I've said too much about that, but one of my primary convictions is that we are mutable creatures, perhaps in bigger ways than we typically think about. So the first one, to learn to lie is to learn to live. I'm putting this with a little more detail than I've talked about it. Human flourishing, not just surviving and adapting, but flourishing involves learning to die, because death gives intensity and meaning to life. This is a theme I'm going to pick up in 2 sessions and talk about in great detail, but it's one of the kind of baseline thematics of the course. Another way to put it, death is my fini, end. It's the end, it's the conclusion, yes. But it's also my telos, the Greek word for purpose. Death is the purpose, not just the finish line. So that perhaps one might be given to say something like this, if this is a true assessment of our situation. I not only accept, but I embrace my finitude. I'm glad that my life is limited. Now, this is a kind of a generic statement. It doesn't mean that I'm going to be happy to die this afternoon, right? It doesn't mean that. It doesn't mean there are premature deaths. It doesn't mean that deaths are tragic sometimes. It just means that when I think about the arc of my life, the fact that it ends, I think about not as a problem, but as something that I welcome. That I might be deprived if it were not the case that it ended. There would be something amiss. There would be something fundamentally wrong if it did not end at some point. Okay, more later. The problem, mystery, distinction, which I'm sure you're familiar with now, by Gabriel Marcel, the neglected mid-20th century French existentialist theologian. And I've been using it in this way: obstacles to dying well, to having a meaningful death, are problems. And we can work towards solutions. But death itself is a mystery, and if treated as a problem, it makes every dying a crisis. When is death treated as a problem? Here's a partial list. When it is seen as a medical or scientific failure, when it is denied, when it becomes a taboo subject, when it is feared, when it becomes politicized, when it is villainized in a dualistic philosophy or theology, for example, in the phrase, death is the enemy of God. Now, all of this is contested territory, So it's not as if I'm saying this and assuming that you automatically agree with it. I'm just putting this out here as a kind of thematic to work with. Number 3, what is a good death? And here are some candidates we've discussed. A death not marked by pain, abandonment, or loss of what I'm calling here identity-bearing attributes or capacities. So here's the assumption that each of us, in relation to our sense of who we are, have certain kind of capacities or abilities that we think are core, that are fundamental. So when one loses those, one has suffered a great tragedy. Another way that I've talked about this has been the difference between one's biological death and biographical death. And I suggested that it's a great tragedy when the biography ends but the biology goes on. So this is another way of kind of introducing that terrain. A good death might be dying in a way that reflects, completes, or improves on, really? Improves on one's sense of self? I don't know, anybody have that sort of aspiration for what the dying process would be like, that you would grow? Elizabeth Kubler-Ross wrote a book in which she called Death the Final Stage of Growth. And I thought, really? Is our expectation that something like this could happen and that would be a good death, a meaningful death? You understand things you didn't understand before, perhaps. Is that too ambitious an agenda to have? A death that does not burden survivors emotionally or financially, yes. Dying marked by caring, expressions of gratitude, love, reconciliations, hopes, appropriate goodbyes. Meaning not good riddance, right? Or as W.C. Fields said, his last words were, "To hell with the whole world except for you, Carlotta," his mistress, right? An appropriate goodbye, a way of signing off that's gracious, fitting, right, okay. Or a dying that includes spiritual experiences. And we've spent some time talking about what a spiritual experience might mean. And I really am drawn to the studies done by Abraham Maslow, a psychologist who studied what he called peak experiences. I think it's the same that all of us have as genetic, inherent capacity for transcendent kind of understandings of things. And these were, he has a kind of a typology. These are the three I think that are most interesting. A peak experience is being in the presence of or in touch with what's real as opposed to what's transient or passing. Eternal, sacred, holy, all these names are expressions of this kind of thing. It also includes a sense of goodness, beauty, and wholeness, that everything fits together, and that, in fact, you belong to that whole. You're a part of that. And the response then is awe, wonder, reverence, and so on. So these are, kind of classic terms that are talked about by the great mystics. And what Maslow is saying is that, people have these kind of experiences. Almost everybody does. And the question is, what do you make of them? And of course, we've been talking about the fact that the process of dying being one of the more fundamental things that happen to us would be open to spiritual dimensions. Okay, I haven't said a lot about this, although it's an important feature of what we're doing today. We are mutable, always changing. Another way to say this, as historical creatures, we are inevitably altered by all that happens to us. By choices we make, by accidents, by luck, by fate. And incorporating this And then moving on is a part of the human genius. We have tremendous, perhaps infinite capacities for interpretation and reinterpretation of what's going on with us. Maybe this is one of the reasons we've survived. This is a part of our adaptability. We can continue to make sense and reintegrate ourselves through horrendous changes. Sometimes we need a lot of help to do that, but it's a capacity we have. So this is something we need to pay attention to as we're thinking about advanced directives. Another way to put this, there's no fixed or static self. There's no core self that perdures is the word I'm looking for. Over time, it's the same. At least that's my observation. I am so radically different from the person I was at 15 or 25 or 35 or 45 or 55 and even 65 that I wonder sometimes, who it is I'm looking at in the mirror. You ever had that experience? Is this me? Wow. Okay, just a way of saying that we do change, and the change is just a part of who we are, and it's constant. If I make it that far, I'm sure I'll be a different person at 85. And this bottom line, we are partially opaque to ourselves. The way I said this before is that we don't have a transparent window into our own soul so that we kind of know it, like you could sort of look at it and say, yep, these are the 5 features, right? No. We need other people to help us do that. Family, friends, neighbors, people who care about us, people we talk to about intimate things. They help us understand so that the recognition of self is always this kind of interactive social phenomenon, which is what an advanced directive is. It's an interactive document for the future with the people who will be engaged with one in one's passing. So the importance of advanced care planning, this is the point I'm finally getting to, right? In executing an advanced directive and in choosing an agent, we are embracing a particular narrative from the larger anthology of selves available to us. So if you think about yourself not as a nice narrative, which runs from the beginning to the end, but as anthology and a collection of different stories about who you are, then one of the things we're doing in filling out an advanced directive for the time of our death is to say, this is the person I am, right? I am the person who doesn't want tube feeding or does want certain kind of things. Of course, in doing this in advance, it always gives us a little pause. One of my colleagues described an advanced directive for health care is ordering a meal in a Chinese restaurant from a menu that you don't really quite understand 10 or 20 years before you're going to eat, right? It's a pretty sobering thought. Okay, I want to look at advanced directives now, and let me ask, some of you may have brought yours, some of you may need a copy, but this is just for reference. If you would pass these around, I want to walk through it, and I want to ask what issues people have with the way advanced directive forms are designed and what questions you might have. As I remember from a show of hands, almost everybody here has an advanced directive form. Yeah. Anybody who doesn't? Okay. I'll come back and pick on you later because we'll want to know why you don't have one. And there may be some good reasons not to have one. Whoops. Oops. Sorry, I gave you the wrong thing. Oh, no. This is the last thing you want, is copies of my slides. Here. Yeah. Yeah, pass those back up. Those are I'm sorry about that. Yeah, you certainly don't want that. Thank you. Oh, you could line your wastebasket with these. See, this shows my anxiety.
We're going around with these.
Good. They're coming around. The reason I print my slides out is that I am always so anxious that something will go wrong with the audiovisual. And if I have to, I can just talk from, the paper copy. I've had to do that before. Reminds me of the time I was trying to give a talk in the back of an Italian restaurant. And blaring over the mic, was some crooner, talking about when the moon hits your eye like a big pizza pie. So this is much better. Okay. You don't have one? Okay. There are a couple of people up here, I think, who don't have a copy. This is a form which dates from 2014 and is a revision of previous forms which were a little more verbose, as I remember. Notice that part 1 is the naming of an agent. And if you want, an alternate. And notice the directions which say, my agent must follow my directions below. So I'm curious about the way in which you did this. Was it just pretty obvious to you who should be your agent? Pretty clear? Yeah. How many of you put an alternate in? Yeah, almost everybody. Okay, good. And notice that part 2 talks about one's wishes for quality of life, conditions I would not be willing to live with or would be willing to live with. And there are 4 listed. A permanent unconscious condition, such as persistent vegetative state, permanent confusion, dependency in all activities of daily living, and an end-stage illness in which there's no more therapy available, like cancer, heart disease, and so on. And then, following that, your wishes for treatment. And there are 4 listed: cardiopulmonary resuscitation, other life support, IV fluids, medications, and so on, treatment of new conditions, and then finally tube feeding or IV fluids, which is very controversial. We'll talk about that in a minute. Yes? How do I feel about clinical trials for cancer patients?
Because usually they don't go on clinical trials until they've exhausted everything else.
People ordinarily, don't go on clinical trials until they've exhausted at least some of the regular therapies. I don't know that I have any particular convictions about that in general. You may have had some experiences, I certainly have, from friends who have gone on to clinical trials. Two friends in particular that stand out who were younger when they died, in their 40s, and another in his 50s. And their reasons for doing so were kind of heartbreaking to me, because both of them said, I'm doing this not because I want it, because I don't want my children to feel that I'm giving up. But
So, I've had several different...
could you stand?
Sure, sorry. I've had several experiences with it. My husband died 3 years ago with pancreatic cancer, late diagnosis. And, you know, part of the procedure was to go to oncology and then, you know, go through the examining really for trials. The doctor doing the exam said, well, you look pretty healthy for as sick as you are. I mean, I could have just come right out of the chair, but anyway.
Did you hear that?
You look
Tilt
pretty
around.
healthy for as sick as you are. My husband was in his lungs, and again, this was 7 weeks before he died. In his lungs, tumor in his pancreas, his liver was compromised, aorta compromised, and his whole lymph system. And a few other things. He'd already lost weight. So, I mean, it's just unimaginable to me that he would be looked at as a healing specimen for whatever. And he was in quite a bit of pain. So we just said we'd really like to get to the pain clinic or whatever might help with this. And we had to go through that procedure first. I have a friend whose husband also died of pancreatic cancer, and he went through what's called a Whipple procedure, which is a very complicated surgery, and got some extra life with that, but then got into a trial situation, and his wife interpreted that as his getting treatment and not giving up. And he said to her at one point, you have to be realistic. They've made a space for me because somebody basically just died. That's how I now have a space in that trial. And so he, you know, just went through that. And I mean, he was terminal, and there was really no treatment, and he was just kind of, that was his contribution to mankind. And I have a friend in Georgia now who's terminally ill. I'm at that age where there's a lot of this. And she has had, as a non-smoker, lung cancer for 5 years. Lots of different treatments that have worked. And the one she's in now does not work at all. She knows that. But she said she is doing it so her family knows she has not given up.
Thank you. Well, maybe we'll have time to discuss this at the final session. This whole business about the perceptions about giving up, and what is that about? Yes, sir.
2 days ago, my wife and I saw the movie Vice, the story of Dick Cheney.
Yes.
Very interesting movie. He died, his family was there, they all said goodbye. He had awful heart failure. And then, boom, the next scene, somebody who was an ex-football player gets hit by a car and kills. Dick Cheney got his heart.
Right.
As far as I know, he's still walking around today.
He still is.
So, what I'm saying is, it was done. It was a done deal. In fact, they even showed a heart that stopped.
Right.
And then a boom. So you never really know.
So I was going to ask you, the point is then that you never really know.
I suppose.
Yeah.
Making the point. The statement, looking up here, he was saying goodbye. He had a very interesting life, and in his mind, a very fulfilling life. And all of a sudden, he's back walking around.
Yeah.
So some of this doesn't always hold true.
That's right.
Because he accepted it in the movie.
Yes.
Then it was a movie.
It was a movie, yeah. And a very interesting movie. Okay, thank you for that comment. I'm tempted to say more about that, but I think I'm just going to hold off for a while. Yeah. Well, I was going to say this is what Hollywood always does to us. You know the statistics about the number of successful resuscitations in hospitals, in TV programs. It's like 85% of them are successful, when in real life it's like 10 to 15% that are successful. Yes, yes, of course. There's, right. Right. Well, okay. I have a lecture. I have a lecture entitled, "Should Dick Cheney Have Gotten a Heart?" But I'm not going to give it today. Okay? All right. Let me keep moving forward. Yes, sir.
As I look at these wishes in part 2, I'm wondering how legally binding they are. Like, what if my doctor interprets it one way and my agent interprets it a different way?
Yeah.
How's that resolved?
We're going to get there. We're moving in that direction. Yes, ma'am.
Just a comment. My agent is not a member of my family, and I did that on purpose to remove the emotional.
Yes.
I mean, she loves me. She's the daughter of my best child,
Right.
best friend, but I removed my family from the emotional part of it.
Okay, just quick show of hands. How many people have a non-family member as your agent? So some others, yes. Okay. All right. Reasons for advance directives. You know this. Expressing your wishes, right? It also can be guidance for health professionals, also for your surrogate, the agent here, your family and friends. Setting expectations, relieving burdens. A lot of you probably had these kind of motivations in mind when you did. I did. Taking the decision, difficult decision, away from somebody who's going to have a tough time making it, and the possible guilt from denying you some potentially life-extending kind of intervention. Reducing the potential for family conflicts because your spouse and or children and or nieces and nephews, siblings may have different views about this. Reducing the financial and emotional burdens of extended care, and enhancing the opportunities of your progeny. Which is to say, one of the trade-offs I think about a lot is, what will the opportunities for my grandchildren be? And I want to be sure I don't use up whatever funds there might be around that they would receive by, a long extended illness which was very expensive to just keep me in some minimally functional state. That would, to me, be a tragedy. Okay. Who should have copies, and with whom should you have conversations about what's in your advance directive? Your primary care professional, for sure. The members of your family, for sure. Your named surrogate, the agent, for sure. And this is the important part. These are people also with which you need to have conversations. And give your reasons. So it's not quite enough to say, this is what I want done. It should begin with, let me tell you a story about why I feel the way I do. Nobody should be surprised as to what's in your advance directive. And you should be the one to start the conversation, because your relations and friends are likely to be reticent to do that. The initiative is with you. Think about yourself as the agent who needs to start the conversation, and to make sure it has the right kind of tone and the right kind of reasons, and so that the persons that you're talking about with this really get it. They don't have to agree with you, but they need to get it. Remember what I was trying to emphasize earlier. One of the things you're saying in advance directive is, this is me. I am this person. I am this person who doesn't want or does want, right? So it needs to be emphatic in that way. Now, there are some arguments against advance directives, and we'll see if our one participant who hasn't yet signed up has any of these reasons or some additional reason. Incompleteness. It only talks about some of the things that could possibly happen. Other people say it's better to have a dynamic advocate as your agent than a static document, because that person, if you're keeping up with them, is going to be in tune with your most recent thinking. Some people worry that the advance directive will trigger a premature do not resuscitate order or otherwise lead to a neglect of one's medical needs. So that, for example, imagine being hospitalized and the medical and nursing staff say, oh, look at this, Churchill's got an advance directive. That means, he's not terribly interested, so we don't have to pay as much attention to him, right? Well, that just doesn't happen. I've never experienced that in any case. Misunderstandings about what you said in the advance directive, the medical teams, the families, even my own, which is to say I may not have a complete understanding of what I've said here. Artificial nutrition and hydration is an example that comes to mind for me. If you are in the hospital for a surgery, and following the surgery you need 3 or 4 days of artificial nutrition until you're healthy enough to take it in by mouth again, you would want to say, sure, that's not what I'm talking about. So I do want it in those cases in which I have a good chance of recovery. I just don't want it if I'm really terminally ill. Low probability of being used. I think this is getting better, but there was a time in which the usage of an advance directive actually being taken out, read, looked at, and being a force in the decision-making in your care was like 10%. I think it's much better now. I don't know what the statistics are, but I know that the ways in which this is found in the medical record have improved tremendously. So there's a much greater use that it's going to be accessed and used than before. Yes, sir?
Will you talk about ways to enhance the likelihood of its actually used?
Yeah, I think so, although I'm wondering if I have more to say than what I've said before in terms of just making sure that everybody in your ambit of relationships really understands. Did you have something particular in mind?
Well, I'm thinking if you have a copy on file that could possibly handle the hospital that you end up in, possibly, and they just don't really pay attention to it.
It does happen. Absolutely it does. John Danforth, years ago, spearheaded legislation so that on hospital admission, every hospital that receives federal funding, which is, I guess, just about all of them, if not all of them, they have to ask you if you have an advance directive. So that has helped, I think. But I'll talk in a minute about some of the mishaps that occur in terms of advance directives not being used. And maybe we'll have some ideas about how we could help with that. Yes, ma'am.
Well, and also courage to the person that you've anointed to be to speak for you. Courage to say, do not give me.
Didn't you hear this? Courage. Stand up.
Oh, stand up, I'm sorry.
Stand up.
Well, courage, you should encourage, from my point of view, after several deaths recently, the person that you've named as your spokesperson for you, to watch things and to make sure that they don't start with fluids or they don't start something that you've asked not to have, and mainly it's in fluids. And nursing homes in particular will do that sort of thing because it's good for the patient, but it's really not. It extends life, and it's really not a good thing.
Well, a custodial or nursing home is one of the most difficult places to get your advance directive recognized and acted on, in my experience. Hospitals are much better about that. Okay. Language to avoid in advanced directives. And I say elsewhere. Heroic care, unnatural care, inappropriate care, extraordinary care, practically dead, as good as dead, or brain dead, unless this is a diagnosis given by a qualified physician. But, I mean, you see headlines all the time, you know, brain dead woman comes back to life after 3 days or whatever. And not just in the National Enquirer. But it is an official definition of death. It is a way of measuring death, right? So brain death is just a shorthand way of talking about death by neurological criteria. And there's a lot to say here about whole brain versus partial brain death, the higher brain death versus, but you know, we can get into that if you want to, but it's a little off the topic. And hopelessly ill is just, I think, a bad thing to say in general because it's so emotionally charged. Okay. Everything I've said about the problematics of advanced directives, how they can perhaps go wrong, don't really apply to a healthcare agent. That is part one, you know, of the form. And I really do believe this. Naming an agent is probably the most important thing you can do. You're much more likely to know who you would want to have as an agent than to be able to fill out the rest of the document with some degree of certainty. So if you've got an agent, chances are you're in good shape, as long as the person you choose knows you well, is willing to follow your instructions rather than their own preferences, and thank you very much, has the courage to say, you know, this is what she wanted. And I'm trying to honor that. That can be tough. In a hospital, you're on foreign turf. You don't know a lot of the language, you don't know your way around, you don't know the rituals. And to be able to stand up in an ICU unit or in a hospital room and say, you know, there is the advanced directive, she's very clear about it, and I'm here to speak for her and tell you she meant what it says on that form. That takes some courage. Yes, sir.
When you're choosing an agent, is there any weight put on that, whether that person you're choosing is a beneficiary in your will?
I've never seen that be a problem, because the agent is almost always a beneficiary if you have chosen a member of your family.
Could that increase the possibilities of your demise?
Well, okay, he said, could that increase the possibilities of your demise? Maybe so, because one of the things that, for example, we would worry about when we were called into one of these situations as ethics consultants was whether or not the motivations of the family were appropriate, and especially if, you know, there's a kind of an equivocal situation, which happens a lot. They may be in the final phases, or it may be that, you know, they can make a recovery, we're not really sure yet. And if the family is saying, you know, nope, let's call it quits, sometimes families do get interrogated about that, but only when I think they're exhibiting behaviors which suggest that, for example, they're dependent on this person's Social Security check. They're living off of it, right? And then you have to worry with it a little bit more. But That doesn't happen a lot. One of the things I had to remember as an ethics consultant is that 99.9% of all the deaths in Vanderbilt Hospital went very well. And the 0.1% that we got called on were the ones in which there were tremendous problems. So I saw a skewed, population. Good to remind oneself of that occasionally. Otherwise, you begin to think that all families are greedy or, whatever. Yes, sir.
Taking it from the other end, in most cases, the spouse is named as the agent. That's my experience as a lawyer who's written a lot of these.
In most cases, the spouse is named as the agent. That's my experience as well.
And I am named as the agent for my spouse, and I'm afraid that I might not have the courage because I don't want to give her up to say pull the plug.
Thank you. Did you hear this? He says, I'm afraid I might not have the courage because I don't want to lose my spouse. Of course. Absolutely. This is one of the things that one has to think about and rehearse carefully. It's a tough thing to do. It's a very tough thing to do. And it requires separating one's own wishes from the wishes of your spouse and saying, this is so hard for me, but I'm willing to honor what you wanted. That's a very tough thing to do. That needs to be rehearsed in conversations, in cases in which this is going to be hard. Because then you can get into the reasons for this and what it would mean to honor someone's wishes that you love deeply and don't want to lose. Those are such powerful and important conversations. That's why I'm saying it's really a long story, It's like marriage. Marriage is one long, extended conversation, right? With another person. Sometimes it is. But, and this is what it is. It's just an extension of all those intimate conversations you've had about, Anyway, thank you so much for that. That's such an important thing. All right, one more question and I want to move on. 2 more questions. You go first.
So, it would help in thinking about when you're saying that you were called in on difficult situations that had ethical considerations, you mentioned money as being one of the factors,
Sometimes money is a factor.
Say a little bit about what other motivations might be, or just...
I'm going to get to that.
Okay, because it would help in sort of thinking about the agent and the family members, what the contentious areas might be.
Exactly. So I'll get into some of the difficulties with agents and some of the ways in which we run into difficulties. Yes, sir.
Quick statement, this one effective thing, I can think of situations in which whichever box you check leads to a lot of legal difficulties. So could you say a few words on when effective? It's in your form.
When it's effective,
No, when effective, mark 1, I give my agent permission, I do not give permission. And both of these, I see with a legal nightmare.
well, the form is there to help to avoid some of the legal nightmares.
Yeah, for example, I do not get permission unless I no longer have capacity. How is that defined? You go to court to find out.
Usually it's a judgment made by the clinicians.
So it's automatic.
It's a judgment made in terms of the question you would usually think of. Are you oriented? Do you know who the president is? Do you know what day it is? Do you know who you are? Do you recognize people? I mean, it's a fairly low level that's usually used in terms of the criterion. It's not a high level. You don't have to be able to do all your multiplication tables, or count from 100 backwards and so on. It's fairly low. Do you know where you are and do you understand what's going on? It's typically the way I've seen it done. If you call in a psychiatrist, you'll get a different kind of definition of that, but typically capacities for decisional capacity assessments are made all the time by attending clinicians. And sometimes they'll want to back up for that, and sometimes it's just pretty clear. Okay. I want to talk just a little about a provision that most people don't know about, and it is a part of the Tennessee Code that the Vanderbilt group helped to write. What if there is no surrogate named, no agent named? And I'm quoting here my colleague Kate Payne. The goal is to find the best person, right? To know the patient's current health care wishes. You're trying to find the best person to make a decision if nobody is named and nobody is obviously available. This provision goes into effect only if the patient is determined to have lost decisional capacity and no agent or guardian has been appointed or is reasonably available. Then the supervising healthcare professional, the doc, may designate a surrogate. And here are the things that are thought to be important in terms of what a surrogate should be able to do. They should exhibit care and concern. They should be familiar with the patient's personal values. They should be reasonably available. And they should be willing to serve in this capacity. And this is a suggested italicized order of preference in terms of choosing a surrogate. The patient's spouse, unless legally separated, adult child, parent, adult sibling, any other adult relative, or any other adult who satisfies the requirements. These requirements. If no surrogate can be found, this happens frequently with homeless people. The patient's designated physician becomes the decision maker after either recommendation of the institution's ethics mechanism, that's when we get called in to become involved, or the concurrence of a second physician, and the second physician cannot be in a subordinate position to the first physician. And the physician must follow the patient's instruction, or if no advance directive, the best interest of the patient. So there are lots of judgments to be made here if there's no surrogate, but there is a provision for dealing with this kind of situation. The surrogate can make all decisions. Now this is if, right, there's no surrogate designated, right, so it wouldn't apply to all of you. Can make all decisions except artificial nutrition and hydration may be withheld or withdrawn for a patient upon a decision of the surrogate only when the designated physician and a second independent physician certify the patient's current clinical records, in the records, that the provision or continuation of artificial nutrition and hydration is merely prolonging the act of dying and the patient is highly unlikely to regain capacity to make medical decisions. Now, one of the interesting things to me is that they carved out this particular intervention, artificial feeding and nutrition, for an exceptional kind of treatment, which I think shows you something about the way this is thought about generally in the culture. Okay. How many of you have heard of the Dementia Directive? Well, a smart general internist, Barak Gaster, at the University of Washington School of Medicine said, well, all this advanced directive stuff is really fine, but a lot of those conditions just won't apply to most of us. But there's a good chance that, reasonably good, we may have some degree of dementia if we live long enough, 20 to 30% of us. So he devised a dementia advance directive, and for 3 stages, mild, moderate, and severe, he said one can designate in advance any of the 4 options. So it's just like this form, only these are the categories. All efforts to prolong life, treatments but do not resuscitate, but do not resuscitate, and no ventilator. The 3rd category, no hospitalization. So it's like, whatever happens, don't send me to the hospital. If I can get care where I am, that's fine. But nothing that requires hospitalization. And 4th, comfort care only, just to prevent suffering. So no interventions, no treatments for infections and so on. There's a website at the bottom of this, and it's very interesting. You can hear an interview with Gaster. These will be available through the OLLI website this afternoon if you want to click on this. It's quite interesting. An interview with Gaster and his motivations and the patients he's seen and the problems that they've encountered. He thinks this is important because the progression from mild to severe can take 8 or more years. And he said people really do want to take the burden away from their family or their surrogate. And he said, people say it'll relieve my anxiety, knowing that there's a plan in place. And knowing that my historical, authentic, I put in parens here, self is less and less available. This, of course, is the great tragedy of Alzheimer's, is that you cease to be yourself, and in some horrendous cases you become actually somebody else. Okay, anyway, I just thought you'd be interested in a dementia advance directive. It's more likely that that's the one we're going to need, actually. Now, why do advance directives fail? And this is my own little list from my experience. There are other reasons too. Who knew he had one, right? Or nobody can find it. It turned out to be in his lockbox at the bank, right? Which was great, since we unlocked it a couple of days after he was dead.
Are there forms like this for dementia?
Yes, there are. There are forms for dementia, and you can download the forms from that website. The person who has it is not a member of the family. It is buried in the medical record at some other institution. There's a medical bias against advance directives because they're just a little too vague. They don't sometimes speak precisely enough, physicians think. As I say, I think the medical bias against advance directives is diminishing. Pardon me. There's an equivocal or contested diagnosis. The family member objects, or a family member objects. Our shorthand way of talking about this on the service was, oh my God, the daughter from California has come. Usually estranged from the family member in question who is seriously ill and ridden with a whole variety of different emotions, guilt being among them. The person designated as an agent doesn't know they are so designated. Now this, honestly, sounds strange, but this happens. The person designated as an agent disagrees with what the advance directive says, or believes it is invalid, or finds that he or she can't really accept responsibility. This is just really understandable to me, because we've talked about what a hard thing it is to do. You get to the point and you say, you know, I just can't do this. Anyone else had an experience that's an addition to these? Yes.
If you qualify brain dead, dementia, whatever. Who puts you to sleep?
What do you mean, who put you to sleep?
With a pet, you take them, if you're putting the dog down, they give them a shot and the dog is no more. But if all of these things fall in and you say, look, I don't want to be alive if I've got dementia or if I'm just clinically ill, though I could live another several weeks or years, who puts you to sleep?
Who puts you to sleep? You don't want to live any longer. Who puts you to sleep? That's a great question, and I'm going to defer it because we're going to spend some time talking about palliative sedation as an option in terms of terminal care, and also such things as stopping eating and drinking as a way of assuring your demise. Okay? All right. We'll talk about that later, so don't forget what you've asked. It's an important question. Thank you. All right, some cautionary tales. I'll see if I can find the right paper this time. I want to talk about 3 situations and ask you to think about them with me in terms of the question, are there lessons here for the whole advanced directive business? Ha! No, that's not it. Can't find it. I'll have to tell you about it. From memory. Robert Wentland. This is a case from the mid-1990s in California. Wentland was in a severe automobile accident, thank you. He emerged after about, as I remember, 8 or 9 months of really intensive care to a low level of consciousness. Now, what I mean by that is that his wife and his children said they didn't think he recognized them. He was paralyzed on the right side. He was incontinent of bladder and bowel. He could respond with lots of prompting to, for example, catching a ball if you tossed him one. He was also able, with a little prompting, to move himself forward in a wheelchair. He was tube-fed, and during a period of about 6 months, on 4 different occasions, the tube fell out and had to be reinserted. On the 4th such occasion, Mrs. Wentland, Rose, said, I've talked about this with my kids, and we don't think the tube should be put back in. We think that Robert would really want to die in this circumstance. The hospital ethics committee met. They agreed. The attending physicians agreed. There was an ombudsman for the county who came and talked to Wentland and to the family. They agreed. Robert's brother said, yes, we've talked about this. He would not want to be left alive, but he had not filled out an advance directive. Okay? So they were just about to say, okay, it's really time to stop, when Robert's mother and sister entered the scene and said, no, no, no. That's killing him. We can't do that. So it went to court, and the California court said, we think it's very likely that Robert Wentland would not want to be alive in the current circumstance. However, we don't have quite enough evidence to push us over the border. So the tube goes back in. About 6 years later, this case was finally settled, by the California Supreme Court. But by that time, Wendland had already died of pneumonia. So he spent about a little more than 5 years, as I remember, in this state. So what are the lessons from that scenario? Have an advanced directive. Have an advanced directive. Absolutely. Make sure your mother is not the agent. Great. Good. The interesting thing is that Wendland really had had some conversations. He just didn't have them with enough people not to be absent an advance directive. Of course, nobody thinks they're going to be in an automobile accident, right? So he was thinking, maybe I'll get around to it. It's another interesting question. How old were you when you first did your advance directive? Early on. Okay.
Why did he have to have two?
Because he couldn't take food orally. He couldn't be fed orally, right. He couldn't feed himself, and he didn't have enough of a swallowing capacity to. Okay, Henry Bush. Now these last two are cases I was involved in, and the names have been changed, to protect the innocent. Here's time one for Henry Bush. April 2016, he is age 80. He suffers massive head injuries from an unimpeded fall on his face from a standing position onto a tile floor. And so he was really cerebrally compromised. Prior to his fall, Mr. Bush was in reasonably good health except for increasing problems with balance. He and his wife, Gertie, who suffers from a moderate form of Alzheimer's, are being cared for by their daughter, Sarah, age 55, who has recently moved to Nashville from St. Louis to care for her parents. Sarah has retired from a career as a child development specialist. Surgery for Mr. Bush following his fall was unsuccessful, and he is comatose and ventilator dependent. Time two. Mr. Bush has now been in the hospital ICU for 2 weeks. His chances for improvement are described by the neurologist as exceedingly small. She said less than 1%. And something I learned is that it's very rare for a physician in this context to say, just absolutely no chance. There's no way Mr. Bush is going to wake up. Typically, they don't say that because they're very chary of being mistaken about this. Perhaps they have been in the past because clinical judgment, is an art as well as a science. So she says less than 1%. Mr. Bush has an advanced care planning document, duly notarized, which dates from 1996, so it's 20 years old. It says that should he suffer from permanent loss of consciousness, that no effort be made to prolong his life. The medical team is ready to shift to palliative comfort care and transfer him to a hospice unit and remove the ventilator and the feeding tube and allow him to die. But Sarah, the daughter, is reticent to discuss this option. She says it feels like giving up. She also questions whether the advanced care plan is still valid since it is 20 years old, and she says that she was never informed that he had such a document. It was Gertie who was named as the agent for Mr. Bush. She also is emphatic that her father's religious beliefs and her own forbid her from agreeing to removal of life support. She added her father would not have rejected his current quality of life because, quote, he liked being waited on. Yeah, don't we all? Who said that? So what are the lessons here?
He should never have been put on the ventilator.
Well, I would disagree. Here's the comment: he never should have been put on the ventilator. Sometimes people are put on the ventilator to see if, in fact, they will have some kind of recovery. The trick is to say, this isn't helping us, so let's remove it. How did they find the advance directive? Well, yeah, right. Well, Gertie had the advance directive somewhere in her papers, and it was finally discovered. But the daughter was very unhappy about this. In fact, one of my little jobs was to talk Sarah into giving me the advance directive, which she would not do, but she did let me look at it. And, you know, it was pretty clear what he wanted. So then she began to argue that it was invalid. In fact, 20 years old, she didn't know about it. If she didn't know about it, she was the primary caretaker, and so on. And then she had, a barrage of reasons why this would not be a good thing to do. So what are the lessons here, do you think? Yes, ma'am? Your doctor should have a copy, yes. If you, this is one of those things where the specialist, the neurologist, needed to become aware of it, and how she would become aware of it is a good question. I don't know where Mr. Bush's primary care doctor was. I don't remember if he was ever on the scene. Well, maybe so. Yes, sir. That's exactly right. I mean, I would say at least once every year or two, you would need to take a look at it, figure out who's got it, and see if you still agree with it. I think that's right. An older document is going to be a little more suspect than one which is, more recent. Yes, sir.
I go to Vanderbilt, and every time I show up for any doctor, they say, have we got your advance directive on file? No? Bring it in next time.
Yeah. That's why they keep saying this. Yes, I know, right? Yes, sir.
I assume one of the lessons is there, presumably, I'm assuming there was no alternate. That would be one.
That's right. There was no alternate. So having an alternate would be a way to perhaps around this situation. But of course, the biggest issue here is getting Sarah on board with what's up here. Can you understand the reluctance of a 55-year-old woman who has given up her career, moved to Nashville to take care of her parents, and what happens? Her father falls on her watch. Oh, she was so guilt-ridden from responsibility that this had happened to him, knowing he had balance problems. So his death was, in a sense, something she just wasn't prepared to take in. Yes, Kathy. No, not Kathy, sorry. Did you have your hand up? Yes.
I was just going to say that one of the biggest problems that needs to be addressed is all the family members needed to have been talked to.
All the family members need to be talked to. That's absolutely right. Okay. Thank you. Let's do one more.
Is there a law regarding the document that it stays clear until, or in force until another document is created?
Yeah, it's enforced until you revoke it. You can always revoke it. You can say, all that stuff I put in the AD, nah, I didn't mean that. Yes.
Can you say what happened?
Yes. I don't know. We sometimes don't know the final ending, but we were unable to convince her, and Mr. Bush was discharged to a very high-tech unit that did tube feeding and ventilator support at great expense, I would say. Well, this was a 2016 case. Yeah. It's possible, but I would doubt it because his cerebral injuries were so severe. Jeremiah Clark, age 74, was hospitalized with increased weakness, abdominal pain, and jaundice. His past medical history is unremarkable except for the placement of a pacemaker 3 years ago. Further testing indicates advanced pancreatic cancer. Mr. Clark shows little interest in participating in his care, and the person accompanying Mr. Clark, who is constantly present in his room, has formed a good relationship with the professional staff. She is consulted for decisions about his care and often relied upon for communication with Mr. Clark. Palliative care and ethics become involved, and after several discussions, it becomes apparent that Mr. Clark has an advance directive executed some years ago, but he has no interest in discussing it or revealing its contents. Subsequent conversations indicate that the advance directive is in the possession of his wife. As it happens, the person accompanying Mr. Clark, who has shown consistent care and concern, is not his wife, but his girlfriend. The wife, rather than the girlfriend, is named as in the advance directive as the surrogate. This happens more than you might think.
Can a hospital give a divorce?
Can a hospital give a divorce? No, I don't think so. I don't think so. I think that's the last slide. Okay. Lessons here? Don't have a girlfriend, or give her your advance directive. Yeah. Well, it had a nice amicable ending in the sense that the wife came in, and Mr. Clark said, "Yep, that's my wife, that's my advance directive, that's what I want done." And, he was discharged to palliative care. So it all went fine. But it's just this idea that keeping up with your advance directive in terms of the agency and who has it is just a very important thing to do. So, one more question.
Years ago, I was involved in a production of a television show back in the 60s. It was a roundtable discussion, and the topic of the discussion was entitled "The Pornography of Death."
The Pornography of Death, a program, yep.
This stuff kind of brought back 50 years of thinking about it. And there's a lot of people, doctors, hospitals, funeral homes, different places that I can say that doesn't work, but because keeping the person alive or keeping or making sure they're dead, there's profitability. And it's
Yes.
funeral homes in particular.
The profitability of death in our culture. This is the Jessica Mitford book we talked about earlier, It's still, I think, quite prominent. Excellent point.
I missed that lecture.
That's all right. Thank you very much. I'll see you next week.